Perfect.
Welcome all of you to the 35th live webinar on orthopedic principles. This time, our guest of honor is Professor Minoo Patel from Australia. Professor Minoo Patel is an orthopedic surgeon based in Melbourne, Australia, specializing in upper limb surgery, trauma, and limb reconstruction. He is the chair of Australian Orthopedic Association Research Foundation and former chair of orthopedics at Cabrini Health. He is fellowship director of the Upper Limb and Limb Reconstruction Fellowship at Epworth. He is associate editor of the Journal of Limb Lengthening and Reconstruction and is on the editorial board of the Indian Journal of Orthopedics and section editor for the Upper Limb. He completed his orthopedic training at KEM Hospital, Mumbai, and in Australia. He has undertaken fellowships in Boston and Baltimore, United States. He completed his PhD in membrane-guided bone regeneration. He has authored over 70 publications and has over 250 presentations. He is adjunct professor at Armit University, Melbourne. He's senior lecturer at Monash University and research fellow at University of Melbourne. It is my honor to introduce you to Professor Minoo Patel for this live webinar on orthopedic principles. Over to you, Dr. Patel.
Thank you very much, Hitesh. Excellent job that you're doing with this Orthopedic Principles webinar, and I hope to contribute to this series for the education of others. So this is one of my pet topics, proximal humerus fractures. And the most important issue, of course, is do we conserve, do we fix, or do we replace? These are my declarations of interest. One in particular is relevant. I am developing a proximal humerus plate and a nail with a company called Ostafix, but it is still a long way away and in no way influences my views. So let's get down to business. When you look at the fractures of the humerus and you replace the, you look at the upper fractures, the proximal humerus fractures, that's in the red dashed line, you will see that there are two bumps. One is sort of at about 57 plus minus 10, and the other one is the 75 plus minus 10. And it's interesting that the 57 bump has moved further and further distally as people are staying active for longer. And that generally tends to be what I call the crazy and young people, mainly males. And then as you get further and further towards old age, you have the osteoporotic females. And you compare that to, for example, say a distal fracture, where you'll have a big spike for the supracondylar fractures and then it peters away. And of course, the shaft fractures keep chugging along. But increasingly, proximal humerus fractures are a greater health burden, not on par with the neck of femur fractures, but pretty much getting there. So in terms of the classifications, we are all aware of the old Neer's classification. It goes in parts, part 1, 2, 3, and 4, the head, the lesser tuberosity, greater tuberosity, and the shaft. And Neer basically suggested that a 1 centimeter displacement and a 45-degree angulation was important to consider a part as a separate part. And that's important because 45-degree angulation is way too excessive. It's not as if you can accept 30 or 20 degrees angulation, but we'll come to that. But, you know, at the end of the day, it is a very simplistic classification. I mean, it doesn't tell us what we need to do to treat and fix a particular fracture. It does not even tell us which ones to fix. And then to make things even more complicated, you have this sort of Hertel classification or Sandow classification, which is essentially this binary Lego classification. But when you look at it, essentially it still talks about the 4 parts. You know, yes, those 4 parts are important, but we have to move beyond the simplistic understanding of part 1 to part 2, part 2 to part 3, and so on and so forth, because again, it does not tell us how to manage the fractures. What I find extremely useful is the AOTA classification, and I'm delighted that more and more people are accepting this classification. And so you have the sort of 1-1, which is the proximal part of the humerus. And then you have the A's, which are the extra-articular unifocal fractures. So essentially your two-part fractures. And then you have the bifocal fractures, where again, the B's are the extra-articulars and the C's are the articular fractures. Now, it's very important that, as I'll show later on, plain X-rays can be very confusing and mislead you. So you do need CT scans, and certainly where I come from, I have to specifically ask for fine cut CTs, i.e. Cuts less than 0.5 millimeters, rather than the standard cuts, which are much coarser. And the reason you need the fine cuts is because you need to extract greater amount of data so that you can get a volume rendered 3D model, which you can then rotate in space, which is the only way you can get a very clear understanding about these fractures, especially if, like me, you're going to treat them with minimally invasive approaches. You do need to have a three-dimensional understanding of these fractures. The other important thing that you note with the OTA classification is the patterns. See, us humans, we are creatures of pattern recognition. And this clearly represents pretty much comprehensively all the patterns that you see. So for example, a 1-1-A1 is a tuberosity avulsion fracture. A 1-1-A2 and A3 is a low and a high energy two-part or a surgical neck fracture. You come to the B's and you typically will see the B2 and a B3 as your Varus impacted fracture. And then you come to the C's. These are highly comminuted fracture, but the pattern C2 is your typical valgus impacted fracture, which you will see in the elderly patients. And then, of course, you have the C3s, which are the fracture dislocation, where the head is out of the glenoid articulation. In this case, as a matter of fact, only was referred to me today. And it shows you the importance of a good quality CT. So the referring doctor from the ED rang me up to say, this was one of my old patients, and she'd had a fall this morning, and they were planning to just treat this conservatively and let her go. This lady, she's slightly osteoporotic, but she's only 68 and very, very active. So if you look at the plain X-ray, you'd say, yeah, okay, there is probably a lesser tuberosity fracture, as you see on the left, and there is a surgical neck fracture and it's impacted, and you could easily leave it be and treat it conservatively. Till you do a volume rendered 3D, and if you look at the image on the left, it seems to suggest that everything is fine, but the whole idea of doing the 3D rotation, if you see in the central image, the greater tuberosity is off, and it is completely off its bed, which means even if it heals, the rotator cuff is not going to be functional. And the image on the right shows that there is a fracture of the lesser tuberosity as well. If it was only the lesser tuberosity, we would arguably treat it conservatively, but this greater tuberosity fragment makes it imperative that at least we offer the patient the option of getting it into anatomic position surgically. So my logical thinking is operate only if you can improve the outcomes. And the things that I consider are anatomy, function, time to mobility. It's also very important not to burn bridges, and it's important when you're considering what your salvage options are going to be, which basically are going to be arthroplasties. So if you look at the main title, so conserve, so you can treat non-operatively with a sling, you can fix by whatever way you are familiar with, and then arthroplasty. In the good old days, it was the hemiarthroplasty, and of course now reverse total shoulder replacement. So here's a very good example of so-called non-operative treatment. And this is a slide given to me by my good friend, Mckee. And it shows very clearly that just because it's conservative treatment doesn't mean you forget the principles. You can see the top view in inter-rotation. There is a malrotation in malposition. You need to have it in neutral position so that you have good reduction in anatomic alignment. And this is because of the forces that act on even a two-part fracture, where you have the internal rotators, the external rotators, and then the muscles that want to pull the shaft into adduction, such as the teres major, the pec major, and the lat dorsi. And then, of course, you also have the deltoid on the lateral aspect. So all of these muscles create a sort of an imbalance depending on where the fracture is. And again, you can clearly see that these two-part surgical neck fractures, there's a lot of force that is directed at the fracture site, especially with a stiff arthritic shoulder. And these, at least in my experience, have a very high risk of non-union. So these are not simple fractures. Just because it's a two-part fracture doesn't make it a simple fracture. You've got to be extremely careful dealing with these fractures. So there is no proximal humerus fracture talk that can be complete without addressing the elephant in the room, which is the PROFHER study. Essentially a good study, but published in the JAMA, which is a high-impact journal. That's a non-orthopedic journal. And that's important because the paper has been slanted towards the general physician community. Certainly, they were very proud, Rangan's group, that they had achieved this very big study, and they also claimed that they had doubled the number of cases in any RCT for the proximal humerus. But that doubling has come at a price. It is important to know that this is called a pragmatic study, and often pragmatic basically becomes a byword for useful in a study, but as I will come to later on, it brings in certain issues which do not make the study a good study to guide your management decisions. So if you looked at the PROFHER study, surgery versus no surgery, no difference on the Oxford shoulder score. We might as well finish the talk and say, right, there's no role for operative management in any of these fractures, but that's not really true. There were comparisons by age, people over 65, people under the age of 65, and comparison by tuberosity involvement, which is what I find a little bit interesting, because on the one hand, they did not consider the Neer classification important, but on the other hand, they took tuberosity involvement as a major issue. And this has been brought in because one of the treatment arms consisted of hemiarthroplasty, where tuberosity involvement and non-union becomes an important issue. But again, if you look at this chart, there is no statistical difference whether you operate on someone or not. So let's dig a bit deeper into the study. Firstly, it's a very heterogeneous population. You saw the double bump that I showed. People over the age of 16 were involved in this trial. I would have probably kept it restricted to patients over the age of 45 because the younger group is a high energy group, and you cannot possibly think about doing non-operative management other than for very minor low energy traumas in that particular age group. They also looked at the degree of displacement, and that was found that the Neer criteria, quite rightly, they said that these were very arbitrary criteria and arbitrary thresholds, and therefore they decided to put them out. But at the same time, when they did their allocation, they used tuberosity involvement as one of the things that they would build into their allocations as a matter of stratification, which again is contradictory. And they also, when they were reporting on the study, they were looking at the Neer classification, but nowhere do they really mention what groups do better and what groups don't. Then it comes to the heterogeneity of the surgical management. It could be screws and plates, and we don't really know whether nails were involved in this particular study because nothing is mentioned. Or a hemiarthroplasty. We don't know what type of hemiarthroplasty was done. We don't know whether the tuberosities were attached. And this is important because certain hemiarthroplasties allow you to get a much better fixation of the tuberosities, because the hemiarthroplasty, like a total shoulder, is a rotator cuff dependent procedure, and if the cuff is non-functional because the tuberosities have not healed, then essentially it's a failed procedure. And then when it comes to the analysis, again, rather than looking at the various fracture patterns, they were more concerned about smoking as a status affecting whether the patient would do well or not. Now, smoking is a risk factor for non-union, but you don't get non-unions generally in metaphyseal fractures. You get malunions. And certainly it wouldn't seemingly affect the hemiarthroplasty group other than to cause issues with tuberosity healing. So essentially what we found was that it was a very heterogeneous population with heterogeneous treatment groups, and therefore really would not tell you which groups were going to do well with surgery and which groups were going to do well without. This is the paper that really brought it home for me. This is from Ghert and Mckee. And this is a PROFHER critique in the Bone and Joint Research Journal, which is a part of the BJJ. And their critique, as I show you here, is that the number of so-called four-part fractures, if you compare it to study by Dean et al., there were about 25%. Various studies have shown even a higher rate, whereas the PROFHER study had very few four-part fractures. Furthermore, we talk about the heterogeneity of the surgeons, and this has been misunderstood a little bit. So it is not that if only one or two surgeons in a particular center contributed one or two cases to the study, because that doesn't really make a difference if everyone is performing at the same level, though it does build into some amount of heterogeneity in the terms of the outcomes. But putting that to one side, what they found was that there were so many exclusion criteria, such as associated dislocations, or because 87 patients had a very clear indication for surgery, and we don't know what those clear indications were. What it tells us that every center discarded a large number of patients for the study and included very few patients. And this can have a major influence on how well the non-operative patients will do. And so what Sabharwal and al. Had said, and what is quoted in this paper, is that it does not tell us, the PROFHER study does not tell us on whom to operate. And we simply cannot accept what the PROFHER study says, basically, that whether you operate or not operate on proximal humerus fractures, the results are the same. So you would have to take the PROFHER study not with a grain of salt, but with a pound of salt. If you do decide to operate, then there are all sorts of fixation options. You got screws and wires, and the wires can be on their own, or there are various external fixation type devices where the wires are on external blocks. You got the stock standard plating system, and one of the most important advances in fracture fixation, but especially proximal humerus fracture fixation, is what I call as fixed angle plates or locking plates. When I started my training, we did not have locking plates, which made it very difficult to fix metaphyseal fractures, especially such as these. And then even the intramedullary nails have improved significantly. We now have nails where the interlocking screws are also locked into the nail. And this makes it very useful, especially for two-part fractures. But at the end of the day, when you look at a fracture, here's an example of what I would call a 11A3, a stock standard two-part fracture. And I've used a straight nail, and certainly straight nails are much better for proximal humerus fractures than the curved nails. And I personally do not believe there is much place now for a curved nail, which enters from the GT. But most of these fractures should be, if fixed with a nail, should be fixed with a straight nail with a cuff splitting approach. But if you look at this fracture and you look at it purely from the point of view of a two-part fracture, which you're going to fix with a device, you're missing out something very important. And this slide demonstrates that especially with these massively displaced fractures, we must look at the soft tissues, artery, vein, nerves. This lady came with a pulseless white hand, had to be taken to theater urgently. And once I'd stabilized her humerus, the vascular surgeons did a bypass graft for a transacted axillary artery. So the soft tissues are extremely important in these particular fractures. Here's another example where you have a fracture dislocation. And in those days, because we did not have locking plates, we did not want to do excessive dissection. And we chose to fix it with wires, which is an effective way. And of course, in the pediatric age group, where you have that little small spike. You probably may or may not have seen, there's a small spike in the periadolescent age group. And this is when they have a proximal humerus fracture where the shaft buttonholes through the deltoid, and retrograde titanium elastic nails can do very well in this group. My go-to option is always now a direct lateral, minimally invasive tube incision approach with or without traction, using an arm holder, image guided, and using a plate. In this case, it's a Phelos plate with what I call it the MIPO jig, which allows you to put the distal screws without having to make a bigger distal incision. But of course, the plate only holds the reduction. Achieving the reduction is the most important thing. So I do my reduction using traction. I use indirect reduction. I also use joysticks, whether it's a bone lever or a wire or a ring handle spike or a pelvic tamp. I tag the tuberosities. That's a very old-fashioned teaching. You tag the tuberosities. And the strongest point in tagging the tuberosities is the bone tendon interface, the interface between the greater tuberosity and the supra and infraspinatus tendons, and the lesser tuberosity with the subscapularis tendons. Unless there is a tear in the bicipital groove, I don't go looking for trouble with the biceps tendon. Very often the biceps tendon scars down, but the intra-articular portion stays in place. In terms of the nail, as I've mentioned, it's very important, especially with these proximal fractures, that we use a straight nail with a cuff split central entry point. So the entry point is medial to the greater tuberosity. It is within the rotator cable. It's just a standard 1 centimeter slip, and the cuff can easily be repaired with a single stitch. And increasingly, the modern nails, such as this multi-lock nail from Synthes, they even have the ability to put an oblique calcar screw if necessary. So this was again a 11C3 fracture, which was a 11A3 fracture, which was very comminuted, and we felt that the calcar screw would give us additional support. So here's the example. It's a very, very small incision. You can use it generally for the 2-part fractures, but not other fractures. And you can do it under image guidance, very small incision. And you split the cuff, you make the entry point. And I actually now use the approach even for shaft fractures. Even when using the traditional curved nails, I do not use the GT as the entry point. But what about shoulder hemiarthroplasty? Hemiarthroplasty was a very good option before we had the reverse total shoulder. And some surgeons are extremely good at doing these hemiarthroplasties. But at the end of the day, it is a cuff-dependent procedure, and the tuberosities must heal. Some implants, such as the one that is shown here, it's the old Neer implant, where you could put bone graft within the hollow space of the proximal aspect, the metaphyseal part of the hemiarthroplasty, and then additional bone graft so that the tuberosity height could be easily maintained, so that the rotator cuff would have its lever arm. But another very important thing, and even though this has been done by a good experienced surgeon, you can see that the Gothic arch that you see between the medial aspect of the humeral shaft and the lateral aspect of the scapula, the Gothic arch is slightly broken. And there are various instruments that are available. I remember using the Neer device, where you would measure with a metallic instrument what the height on the opposite side was, and you would translate that into the operative side. But at the end of the day, it's actually surprisingly technical and technically difficult procedure. Compared to the reverse total shoulder arthroplasty, what the reverse total shoulder arthroplasty has done is that it has equalized or leveled the playing field for arthroplasty for trauma. And the reason is that it is a cuff-independent procedure. If you don't get your height right, you can build it up, as you see on the right-hand side. We've stacked up to get the appropriate tension. Tuberosity healing is of secondary importance only, because even though some people suggest that the tuberosities are important for rotation, I believe rotation mainly occurs by the differential action of the deltoid muscles. The important role of the tuberosity, at least initially, is to give some additional stability to the implant. And you could do the reverse total shoulder from a deltopectoral approach or from a direct lateral approach. And the importance is that if you are planning to do a reconstructive procedure such as internal fixation, and if it fails, you could always go and use the same incision to do your salvage reverse total shoulder arthroplasty. And this is a very, very good indication of the quality of the result that you can get. This lady is in her late 80s, and that's the kind of function she can expect after a reverse shoulder for trauma. As I mentioned earlier, have this dictum of not burning any bridges, and there are various studies now that show that reverse total shoulder arthroplasty outcomes are best when it's done as a primary procedure. Revision to a reverse total shoulder arthroplasty from any previous procedure, and this included not just trauma, but even cuff repairs, but especially with trauma, or from a hemiarthroplasty, the revisions generally have inferior outcomes because of stiffness and poor deltoid function. So let's go through each of these subgroups, and we'll see what little pearls we can give you in managing different types of fractures. So this is, again, one of my pet hobby horses, the greater tuberosity avulsion fracture. Highly underestimated, and people think about it as just a greater tuberosity rather than thinking about it as the attachment of the most important tendon in the shoulder, which is your rotator cuff. So this is the 11A1, and you can see quite displaced. And after trying various options, which I'll come to, I've now settled down on using the Phelos plate or a lateral locking plate with suture holes for putting tension stitches for the rotator cuff as my major treatment option. And that's because the plate acts as a buttress and cinches down the tuberosity into its bed. In this particular instance, the greater tuberosity always goes not just lateral, but also goes posterior. And if you are going to treat this non-operatively, it is very important to look at serial x-ray. So here's the x-ray on the left on the time of the injury. And in 2 weeks' time, the rotator cuff kept pulling the tuberosity further and further out. And you can see how badly displaced it is on the volume rendered 3D model. And so what I would do in this instance is use a traction stitch and bring it into position and temporarily pin it with a wire, and then use my standard 2-incision minimally invasive technique to put a buttress plate, which is what we've done here. This also allows me to show you something very, very important. You don't need a whole lot of screws. I only got 4 screws proximally and 2 screws distally. Literally, that's all you need. The other thing is you must be able to take whatever technique you use, direct lateral, deltopectoral, with arm holder, without, you must be able to take an extremely good quality direct lateral view, because as I'll show you, especially with the deltopectoral approach, the plate tends to go off distally, which basically means that you didn't start off at the appropriate spot proximally. The good thing about doing these buttress plate fixations for the greater tuberosity fractures is that you can start mobilizing them straight away. But there are various options. You can use screws, but if you use screws, you need washers, because that fleck of bone is pretty thin, pretty small, and anyone who's done a rotator cuff repair knows that that bone, especially slightly anteriorly, is relatively soft. I have flirted in the past with arthroscopic GT fixation, and now I would use it mainly for the very comminuted, superficial, true avulsions of the rotator cuff, where I essentially treat it like a rotator cuff repair. But I've certainly stopped doing this for these big GT fragments. Sometimes with arthroscopic surgery, it kind of becomes an end in itself rather than a means to an end, and it becomes an article of faith with shoulder surgeons. And I certainly find, again, that especially if you're using impaction anchors rather than screw-in anchors, the fixation can be extremely poor, especially in the metaphyseal areas. And I'm much happier doing a buttress plate for these. Let's go to the Varus impacted and the Valgus impacted fractures. You can clearly see what the two main deforming forces are in this case. You've got the rotator cuff wanting to pull the fragment into Varus, and then you've got the deltoid, which wants to pull the shaft fragment into abduction and also into proximal migration. This is where the original concept of the calcar reduction came in. The other important thing about the calcar is that that's where the blood supply comes in. There are numerous studies that have shown that the medial soft tissue hinge is extremely important. And this is one of the problems with these comminuted fractures, especially if you use a deltopectoral approach. The tendency is to inadvertently damage the blood supply, which is why, since we've started doing the direct lateral approach, we haven't had a single case of avascular necrosis. But to depend on just the plate and fixed angle screws in what can often be a shell of a proximal humerus to hold the reduction, even if you get a good, accurate calcar reduction, is asking too much, which is why most of these fractures will fail in Varus, and then you will get screw cut out. It's not the screw that is cut out. The screw is stayed in place. It's just the humeral head has just fallen off like an ice cream falling off the cone. And here's a classic example of what happens. This is Mike Mckee's case. And you can very, very clearly see, thankfully, this case at least has gone on to union. You can often get severe malunion or even non-union. A very simple way of preventing this Varus collapse is to use a structural graft. Anything in the intramedullary canal, and it doesn't even have to be a graft. A good colleague of mine, Ed Bateman from up the central coast of New South Wales, he uses an intramedullary 1/3 tubular plate. And it is interesting that people have started doing this even with the Powell's type 3 neck of femur fractures, where the concept of anterior or anteromedial buttress plating to overcome the shear forces has come into play. But what happens is that the structural graft essentially converts the bad compression forces which want to shear off the Varus fragment into further Varus into good compressive forces, which essentially allow for better healing of the fracture. And so I now have a very low threshold for using these structural grafts. And whatever graft you use is dealer's choice. If you have no access to allograft, you can use fibular autograft as well. So the two important fractures that I want to talk about are these Varus and Valgus impacted fractures, which is the 11B2 and the 11C2 fractures. And it's interesting that a study that I'll talk about later on, which looked at reverse total shoulder arthroplasty versus fixation, also looked at these two groups. So once again, I position the patient just like I do my shoulder arthroscopy. But it's very important, a few little tips. You want the patient to be in 45 degrees, but you sit them up at 90 and then you tip them down so that the arm holder gets out of the way. The image intensifier comes from the opposite side so that you're free to operate, and then everything else gets done under image vision. So this was our study. We had 16 cases. We had used cortical strut graft or fibular allograft, 3-hole Phelos plate. I almost rarely will require a 5-hole plate. 3-hole is my go-to plate. Direct lateral double incision approach. We've spoken about the deforming forces, and what you want to do is you want to create a sort of a hat on a hook kind of construct. Here's an example. Here's a valgus impacted fracture, and if you think it's a benign fracture, I'll show you at the end. that it is truly not a benign fracture. And you can see very clearly I'm using a bone punch. And once I've got my allograft into place, I almost don't require a plate. The allograft is the hook on which the hat, which is the head, is resting. And the plate is just to hold everything else into place. And the same thing in a Varus kind of fracture. It's a little bit more difficult to obtain the union from the lateral approach, but trust me, you're nowhere near medially. You can put your finger around the medial aspect and do direct reduction with blunt dissection without damaging the soft tissue sleeve. And the same thing, you can get a similar good reduction. Unfortunately, here we managed to create some comminution, but that was in the process of the reduction. We still did not get any issues with union or ABN. So here's my surgical technique, especially for the valgus impacted. You can see the sleeve of the rotator cuff in my left hand with the hemostats, and you can see the shining bit there. That's the that is your humeral head articular surface. And I've got my tuberosities already tagged with the sutures on either side. And I'm just using a simple ring handle Tritamen spike to elevate the humeral head from its valgus position where it's looking skywards into getting it in contact with the glenoid articular surface. But also what my bone spike is doing is creating a slot for the allograft to go in. I use a long cortical strut allograft wherever possible. I put it down. It's very important that you taper it down so as not to shatter, especially the osteoporotic proximal humerus. And then once I'm satisfied it's down enough, I just take an oscillating saw, cut it down to size, and then tamp it down. And you get this kind of picture where the graft holds the reduction. And then the rest of it, the sutures go through the plate. You don't require a large incision. Everything just goes through a small incision. You just, the other important trick is when you're doing these direct lateral approaches, you go submuscular, but when you put your finger down under the deltoid, you can actually feel the nerve, and you can protect it, and you can then pass the plate down and fix it. So here's another example, same technique. Again, clearly showing in that picture in the bottom center that once the graft is in place, the reduction is pretty much done, and then the plate just enhances the reduction further. And this is the final result. So this is again our study where we had 16 cases. I did get one iatrogenic shaft fracture as I showed earlier, and I had to use a slightly longer plate. But again, this lady went on to heal. Most importantly, we had 0 non-unions as against the PROFHER study, which had 3.2% ABN rates. An issue with these plates, of course, is that sometimes you can get stiffness and sometimes you can get metal impingement, and you may require implant removal. But these are relatively small procedures. If I have to do an arthroscopic release in order to get better movement, I've had as many cases where people have been treated conservatively for almost undisplaced fractures who also required arthroscopic releases. And our scores were pretty much on par with what was seen in the PROFHER study, where the average 24-month average was about 38, 39 in either group. So what is better, a nail or a plate? And again, a lot of these studies, even systematic reviews and meta-analysis, don't really tell you what fracture group or what fracture pattern they were looking at. And if you were to take a very sort of overall but superficial outlook, you seem to suggest that no treatment group is superior. So nails and plates, if appropriately used, are both equally good devices. But they are just tools. They're not a means to it. They're a means to an end and not an end in themselves. And again, another biomechanical study. Certainly what various studies have shown is that the fibular allograft in the intramedullary canal is certainly very, very useful for improving the stability of the construct, even in vivo, as well as in the laboratory. The other important issue is the issue of these calcar support, and I showed you that certainly in the non-locking plates, the calcar screw was very important, and it's interesting that it has made a comeback in the nails, because nails are not essentially rigid angular support, angular stable constructs. But if you look at this study with very simple fracture patterns and with fracture patterns with some medial combination, and even though they conclude that the calcar blade plate, which is their version of the design, is useful, if you look at the data in detail, it actually shows no difference. And so much so, I mean, here's a classic example of what they show, where they use this device and you can clearly see that the fracture has failed and has required a reverse total shoulder arthroplasty. So again, for the younger trainees, read the literature, don't go by what the industry feeds you. So again, a few tips. You can just use a Tritavan's bone handle spike, but you can use cob elevators, some instruments from the pelvic set to do these reductions percutaneously using joysticks. I used to use what you see on the bottom right, bone putty, but I've moved away from bone putty, especially the calcium phosphate putty, because it can extrude intra-articular and it stays there for many months and years and really does not add to the stability. And this is before I started doing the intramedullary strut grafts if required. This is a closer view of the jig that you see. Now, it's very important when you use MIPO plates that you're acutely aware of the axillary nerve and vessels. And if you're starting out initially and now worried, make a bigger incision. Don't split the deltoid too far down, and you can actually dissect out the axillary nerve and the circumflex vessels. And I certainly did that in my first case because I was too worried. But once I got a hang of it, you don't need to do that. But very importantly, you need to do it if you think you need to put the calcar screw. The calcar screw is very, very close to the nerve. But as I said, once you use intramedullary grafts, you really don't require the calcar screw. So in the plate that we are developing, and certain other manufacturers as well, the MIPO jig does not allow you to put the oblique calcar screw. And certainly in our system, it's going to be color-coded as well so that people do not make this mistake inadvertently. And you can see the tiny incisions that we use, and you can also see the temporary wires that we use percutaneously to keep the fragments stable. And of course, everything is done with image guidance. Here's another trick, and certainly people who do the AO courses will remember doing this particular exercise, but you can use, like, for example, as we've shown here, there is an oval hole where you can put a non-locking screw, and you can use the buttress effect of the plate to cinch the plate down to the bone and affect the final reduction, even after the fixation of the head segment, so that you can pull the shaft back into its original position to avoid medialization. So here are a few examples. Again, this is a Varus type fracture which we've reduced and fixed. Here's another Varus type fracture. I find these fractures much more difficult than the valgus fractures because of the oblique nature of the fracture pattern. So it's almost like a Powell 3 or Powell 4, as you'd see in a neck of femur fracture. And certainly in these fractures, I find that if I don't use a graft, the oblique calcar screws are quite useful. I'll just skip through that. But here's another example in a very young person. This guy was ice skating, and you can see the wonderful result that he can get with a minimally invasive two-incision technique for what is a real bad Varus impacted fracture. This is my issue with the deltopectoral approach. You've essentially got a plate that sits laterally, and then you have to go from the front, and you have to retract the deltoid. Some people put the arm in abduction, and then you have to rotate the arm, and you do a lot of dissection and inadvertently go around dissecting the medial aspect. And you can see here There's a patient who came to me after an RF in Rome, and you can clearly see what has happened is that the shaft fragment is an extension. And it is almost impossible to avoid this mistake if you're going to do a deltopectoral approach. And again, you don't need such a long plate. The fracture was pretty straightforward, and you've seen me use a 3-hole plate. Long plates don't really add anything to the fixation of a proximal humerus fracture. Fracture dislocations, they are a very difficult beast. And if the patient is older than 60, I would certainly consider an arthroplasty option, but you can go ahead and fix it in the younger patients. It's important to keep the vascularity of the fragment, but here you can see that the head is almost certainly avascular, and you're going to depend on creeping substitution to heal. And we try not to fill it up with too much metal. So again, coming to the last part of the talk, we're talking about reverse total shoulder arthroplasty. You don't want to burn bridges. If you're going to think about doing it, do it as a primary option. And a primary option, on a few occasions, I've gone in with the aim of fixing it, but had the reverse total shoulder available. And after about the first 15, 20 minutes, you realize that you're not going to get a good result, and you go ahead and bail out and do a reverse. That is still a primary reverse. So the reason the reverse total arthroplasty in trauma is good is because it's stable. It has inherent stability. Now, in a trauma situation, it's important to repair the tuberosity, and you'll see that implants will have special trauma bodies where you can put the sutures through. And as soon as you try and tie those sutures, you get very good stability. Without the sutures, without the tuberosity, the stability is not very good. And then you can start rehabbing these reverse shoulders without waiting for any formal healing of the bone. And so in that effect, it's a rotator cuff replacing procedure, but it is deltoid dependent. And so if you have an axillary nerve lesion, then you may want to reconsider the option of doing a reverse. And if it's non-reconstructible, you may want to do a hemiarthroplasty with a modular system where you could potentially go and do the conversion to a reverse once the axillary nerve has recovered, or you've done surgical interventions such as doing a nerve transfer. And the reason the reverse total shoulder arthroplasty works is because it brings down the center of rotation, and it also pushes it medially so that the deltoid length is restored, and the deltoid can then be the prime mover in the absence of the coapting effect of the rotator cuff. And this again clearly shows you how different parts of the deltoid can work differentially and give you rotation. So even if the tuberosity is not healed, it's not that critical. I tend to use a modular system, so I can convert from a hemi if I do a hemi to a reverse, or if the reverse fails for whatever reason, you convert that to a hemi. But this is a distal fixation stem, and this is very important. This is almost like one of those revision stems that people used for revision total hips. Fixation is all distal. So you can use them even in a trauma situation, even in the elderly, as a press fit implant, and then you can build up on top. So this is the trauma body. That's the SMR system from Lima, but you could use whatever system suits you. You can put a suture around, but more importantly, you can have these holes. And people would be aware of the Pascal Bolet technique where you repair these tuberosities. It's quite a complex sort of technique, but you don't require that sort of meticulous repair with the reverse total shoulder arthroplasty, especially in the elderly. Again, if you're used to the delto-pectoral approach, you can do that, but repairing the tuberosities is going to be difficult. Here's a delto-pectoral approach. You can see that the humeral shaft is sitting out, and then you do the trial reduction and repair the tuberosities. I generally now tend to use number 5 ethibond sutures rather than using any metallic cables. Even if you repair it, often it'll just disappear away, and it does not seem to adversely affect the outcome, especially in terms of the rotations. Most patients, as you saw the video of the elderly lady, will get very good overhead function, which is essentially what they require. So I just want to go down quickly and talk about the Delphi study. So the Delphi study has just been published last month in the Journal of Bone and Joint Surgery. Delphi is DEL for the delta reverse total shoulder, and PHI is the Phelos. So they were comparing the delta, the Pew, and the Phelos plate systems. They looked at, as I said earlier, the 11B2 and the 11C2 in elderly patients. So you see how different and how much more focused the study is compared to the PROFHER. You have an age group where this injury is very common, and you want to compare plate versus reverse shoulder. And you're also looking at the B2s and the C2s, which are the common Varus and Valgus impacted fractures, respectively. So this is what Mckee was saying. We need more studies which are focused in particular age groups and particular fracture types. So what did they show? They showed that reverse total shoulder arthroplasty outperforms the open reduction internal fixation. This is a chart looking at the constant score, which is significantly better at 24 months, but essentially starts off being good very early in the piece because they do not require the same level of rehabilitation and stiffness. What I found interesting was that for a C2 fracture, which is a Varus fracture, it definitely was better because, as I've said to you, my experience is that it's quite difficult to do open reduction with these Varus fractures, which have got a very vertical fracture line. Whereas with a B2 fracture, which was the Valgus impacted, where I certainly would have very little hesitation in offering an open reduction, even to patients over 75. If you do it well, or if does not tend to do as badly. But what is interesting is between 12 and 24 months, the reverse totals constant score was significantly better than the RF group. And whether that was from cuff dysfunction, we don't know. Remember, constant has two important issues. One is the elevation, and the other is the abduction strength, which really contributes a lot to the constant score. And this could be the reason why that group did better. Towards the end, salvage reverse total shoulder. It's harder, the results are poorer, higher infection rate. And this is interesting because this is across the board. You look at total knee replacements, which are done after trauma, and they seem to do worse as well than if it was done primarily. There's also poor function, probably because of the scarring of the soft tissues in the deltoid and higher rates of implant loosening. So for people who think that conservative treatment for 11B2 valgus impacted fractures is a benign option, here's an example where it's not. And we've almost coined a term, and tongue-in-cheek, we call this lady a victim of PROFHER because that's what she was told by a surgeon, that the studies had shown that there was no difference, and therefore in a public hospital she wasn't going to be offered surgery. And you can clearly see the humeral head is still pointing up, like you saw in my operative picture. But what has happened is that the tuberosities have sort of healed in their original position. The head is stoved under, and therefore, of course, this lady had no cuff function. And you can clearly see that the humeral head has migrated up. And again, the plain X-ray, she was diagnosed as calcification in the insertion of the rotator cuff. CD clearly shows that's not the case. Essentially, it's just a tuberosity that has malunited. And you can again clearly see from the front-on view and the rear view, both the lesser and the greater tuberosities have malunited, and the head is just stoved under. And of course, when you have such a poor positioning of the cuff, you get cuff dysfunction, and the cuff just disappears. So I did this reverse total shoulder arthroplasty and felt very good, and she certainly did well for the first 12 months, and then she started experiencing pain, and she went through an infection screen. And at 24 months, we've done a SPECT scan with a CMAR protocol for a CT, and you can clearly see what has happened. This lady's glenoid was so osteoporotic that she's actually pulled off the glenoid, and she awaits a revision. And this is something that we see not too infrequently when we're dealing with sequelae for of trauma where we've done a reverse shoulder arthroplasty. So in conclusion, identify the fracture pattern, choose wisely. The fracture is the key, the technique is important. Implants are just a tool, they're just ways to a mean. Familiarize yourself with the tools best suited to your circumstances. You don't have to be good at everything. And please, on the operating table and later on in your rooms, have a plan B, so if things don't work out, you can still help your patients. Thank you very much, Hitesh, for inviting me for this talk, and happy to take any questions if there are any.
Thank you, Prof. That was a very brilliant lecture from your side. Can you hear me, Prof?
I can.
Yeah. The audience would have really benefited because you're a surgeon who does both extremes, like from conservative to reverse total shoulder. So we have covered almost everything. I'll just read out a few of the questions that have come up in the chat box. One is by Dr. Rajiv Kumar from Chandigarh. His question is, what is the approach that you prefer in a 4-part fracture if you're planning to do a Philos plate?
So as I showed you, I now do, so I don't use the term 4-part fracture, so I've got to know whether it's a Varus or Valgus impacted. And I hope that the humeral head is enlocated. If the humeral head is not enlocated, I would use the deltopectoral approach, but that's very rare. So I would use my standard 2 incision approach, do indirect reduction, and use a graft if necessary. I would use the MIPO jig is pretty new. Before the MIPO jig, I just used the ordinary jig that came with the Philos plate. And I say Philos plate just because it's something that I use. You can use any of the other proximal humerus plates. They're coming in all sorts of funny shapes and sizes, and you really don't require those different shapes and sizes. But I would put the plate underneath, submuscular, underneath the deltoid, underneath the axillary nerve, and fix it. Yeah.
Prof, thank you for that response. Prof, I always do the lateral approach for proximal humerus, like how you've shown. But I'm so concerned about the axillary nerve. I make it a point that every time I go in, I just identify it and then go. So do you always search for the axillary nerve? Because I saw subsequently your incisions have become very small.
Yeah, so as you get more and more confident, your incisions become smaller. But I feel the nerve. This is, one of the, I think it was in Belly and Love. There's a statement that the best dissector in the world is your non-dominant arm index finger, because it's the only dissector that has sensation. So if you put your finger there, you actually can very easily feel the nerve. You can protect it, and your plate goes under the deltoid. And we use the same approach when you do a submuscular anterior MIPO for the humerus. As long as you are under the muscles and you avoid the vessels and you know your anatomy, you should be fine.
Thank you, Prof. The other one question is regarding the use of reverse shoulder replacement. Someone has a concern that is it an overkill for a proximal fracture? Because if it fails, that means the complication rates, according to some studies, are around 15 to 20%. If it fails, and the options are very limited. So is there a real role for a primary reverse shoulder in a proximal humerus fracture?
So look, my group was one of the earliest users for the reverse shoulder. And I must admit, I did that because my results with the hemiarthroplasties weren't all that great. Is it an overkill? No, it's not. So we have our National Joint Registry. I can check my results, and my revision rate is about 3% for all comers. You have to pay attention detail, one of the other important roles of doing a CT scan for trauma reverse is you can check the glenoid, you can look at the bone quality. If the bone quality is poor, then sure, you'd be worried about glenoid loosening. But if the bone quality is poor, then it is going to be a low demand patient anyway. And so my glenoid failures have happened in the setting of the lady that I showed. She's still only 62 and she is a high demand patient, but her osteoporosis is from disuse, and that's why she's had a failure. And even with that level of failure, using a customized implant, we'll be able to salvage her. We've done a few of those. But you really need to be very conversant with doing a reverse total shoulder if you're going to be doing it even for trauma. So, and this is where this dichotomy lies. I mean, should the average non-specialized orthopedic surgeon be doing a reverse shoulder for a trauma? For me, the answer would be no. And if you feel that you are in a locality where you cannot refer on, then I'd suggest go and do a few cadaveric labs and get really good at doing it. See, my generation, we grew up with the reverse. I did my first reverse in year 2000. And I actually find anatomics much more challenging compared to the reverse because you have to do soft tissue balancing, you got to get the glenoid right. Whereas with the reverse, it's such a forgiving operation. And if you essentially do a few things, such as your glenoid base plate should never be tilting up. It can be flat, especially if you're going to use an eccentric glenoid, as happens with the Lima system, or you can tilt it downwards slightly. The version should be 0 or 10 degrees retroversion for the humeral head. And the rest of it is just soft tissue balancing. I generally take the two tuberosities. I don't even call them lesser or greater. I just take the muscle masses at the bone tendon interface, anterior and posterior. And by the time you tie them down, it's very, very stable. They function very well. They don't all get 180. They generally get about 120, 130. But for this age group, they want pain relief first, and they want function second. In terms of rotations, I think, unfortunately, especially the American groups, they overemphasize external rotation. Actually, in women, especially in this age group, they would rather have more internal rotation than external rotation. And that's why neutral version is actually very good for them. If they fail, what's the salvage? The salvage is to do a hemiarthroplasty, which hopefully works as a pain relieving procedure. I don't know whether the question, the person who asked the question could tell us when they talk about failure rates, what are they talking about? Are they talking about deltoid weakness, which can come about at the 10-year mark, or whether they're talking about dislocations or implant loosening or periprosthetic fractures?
Maybe this question is general because maybe it's a bit, the concept is a bit old, because I think when reverse shoulder around 10 years back, people were highlighting the complications more. For example, scapular notching, dislocation, fractures, and maybe the better techniques now has reduced the incidence of all these complications and designs.
Yeah, scapular notching is an issue. Again, in our study, what we found was that the scapular notching would progress for about 18 months to 24 months, and then it wouldn't progress. There are lateralized implants available, though they do not have as much literature in trauma as the other standard implants like Lima or the Delta. Dislocation is an issue, and that's why the tuberosity repair is important. That really reduces the dislocation rate, especially for trauma. I don't move them straight away. So if I'm doing a reverse for a cuff tear arthropathy, I'll move it straight away. For trauma, I will protect them in a sling for about 3 weeks, which again, in this age group, they don't mind. The other important thing, which I probably didn't emphasize enough, was when you're doing non-operative management, pain relief is extremely important. There are quite a few patients now who get so sick and tired of the pain that they opt for internal fixation or an arthroplasty just to manage the pain. And so, especially in the older age group where you're doing a reverse, they get good pain relief, and that is the first step for their satisfaction. I also monitor my shoulder arthroplasties every year. So irrespective of what some people say, I will see them every year to make sure that the soft tissues are fine, there is no wear, there's no loosening. That's how we picked up this lady who raised the flags when she started, her function started deteriorating.
So in your practice, approximately what percentage of patients do you do a reverse shoulder?
Or for trauma?
Yeah, trauma.
Look, I'd probably have to say
approximate. Yeah.
No, above the under the age of 60, none. 60 to 70, I'd probably do about 10% or less. Over the age of 70, I'd probably do reverses in about 45 to 50%.
Okay, so maybe more than 70 is like one of your criteria. Maybe you don't want to do it at 60 to 70 at all.
No, so that was the paper which you can find in the JBJS British proceedings was titled "Reverse Total Shoulder Arthroplasty in Patients Over the Age of 70."
70, okay, I remember.
Yeah. So that was the, So that was the ethics committee wouldn't give us the ethics approval unless we actually said we're going to do it only in the elderly patients. And that was 10 years ago. I mean, our life expectancies have grown up. As I said, I not that long ago fixed an 80-year-old who basically said, I'm not having a replacement. I want it fixed. So you're not going to leave it. You're not going to replace it. You're going to fix it. And we do get these, high demand patients, but she's a retired school principal and she lives by herself, and she, promised to do the rehab and has got a reasonably good outcome.
Okay, thank you, Prof. The other question that has come up is, do you think there's a difference between a total shoulder and a reverse shoulder in a proximal humerus fracture setting? Biomechanically, can you do a total instead of a reverse total shoulder?
No, so your total shoulder arthroplasty is going to be cuff dependent as well. You could do a hemiarthroplasty even in a younger person. And if the glenoid starts wearing, you could do conversion to a total shoulder in a young person if you couldn't salvage it at all. But in that age group, you do everything possible to salvage, except the small risk of non-union or avascular necrosis, and still salvage it, and then do a total shoulder arthroplasty as a salvage option. So in that younger age group, I wouldn't go for a reverse. I know some in the US are doing reverses under the age of 50. I mean, that's what we call reversomania. In the older person, there is no advantage of doing a total, in the sense you are still going to be dependent on a tuberosity for union. And if the tuberosity doesn't unite and your shoulder starts riding up, not only is it going to become painful, but it is also going to cause the rocking horse effect on your cemented glenoid, and it's going to cause it to loosen. So in our national joint registry for all comers for total shoulders, one of the top reasons for revising a total shoulder to a reverse total shoulder is cuff failure. And so the cuff failure risk is much higher in trauma because of the absence of the tuberosities. And so you wouldn't do a total shoulder, you'd stick to a reverse.
Prof, actually, your talk was very exhaustive, so there are a lot of questions. The other one is regarding the PROFHER trial. Now, the PROFHER trial looked at purely surgical neck of humerus fractures, right?
What do you mean by surgical neck?
No, see, I can, it's shown in the abstract. I was just going through when you presented as well. It's clearly saying it looked at surgical neck fractures of the humerus. So I asked Summer Rangan the question, what do you mean by surgical neck of humerus?
They're all surgical neck humerus fractures because you are excluding the dislocations, you're excluding the head splits. So they are all surgical neck fractures. You'd be better off calling them a proximal humerus fracture. And I don't know.
But the title they have given is surgical neck of humerus.
But that's what happens when you put that
anatomy
paper.
Textbook.
Yeah, so how can you get a surgical neck of humerus fracture with a 4-part fracture?
Yeah, it cannot, ideally. So that was, because I was also confused with the term surgical neck that is quoted in the PROFHER trial.
See, unfortunately, and again, I've spoken to a few of the people, including Joe Dyers, who was here recently. The problem is they wanted it to be in a high impact journal, and they almost had to dumb it down. And that's why the Delphi study sets a good example of how to do it. I mean, I wouldn't mind a PROFHER study where they would say we would separate them out in the OTA, 1.1b2s and OTA 1.1c2s, and excluded the B3s and the C3s, and then we would do an intra-group analysis, even if they did not involve a reverse total shoulder. And they're making the same mistake again. They're now having a reverse shoulder arm, but if they're going to do this pragmatic study where they do not control the quality issues, you cannot take those results on face value. The downside is that the insurance companies and the health administrators will glaze through the abstract and come to the conclusion, yep, proximal humerus fractures, no difference whether you operate or not. And then you see these, like the lady we showed, victims of PROFHER.
Prof?
Sorry, I couldn't hear the last bit. I can hear you now.
Yeah. So I think there are no more questions, and we have covered almost everything, and we have discussed as well a lot of questions. Thank you once again, Prof. Patel, for joining us. It has been an honor and privilege for us. You have taken a lot of time to make this presentation, and I'm sure it's going to benefit thousands of surgeons all over the world.
Thank you.
Your 1 hour is going to benefit hundreds and thousands and more.
I hope so.
Thank you.
Thank you very much. Thank you for giving me the opportunity and the privilege of presenting to your group, and happy to be of help in the future. Good night.
Okay, Prof. Good night. Bye-bye. I'll end the meeting, Prof.